Your answer is partly fulfilling the question respiratory monitoring.
Yes, sir.
So the first and foremost is oxygen saturation. When you try to measure the oxygen saturation, the blood does not contain only oxyhemoglobin and deoxyhemoglobin. It also contains carboxyhemoglobin and methemoglobin, which are present in very small quantities in normal health, which cannot be measured by your simple pulse oximetry. So you need an instrument called co-oximeter, and this is a very frequently asked question in the examination. Whenever a patient has got a carbon monoxide poisoning or a methemoglobinemia, can your pulse oximetry measure give the correct values? At the time, they ask what is the other instrument that will be able to identify the content. So co-oximetry is the thing which will be able to measure not only oxy and deoxy but also carboxyhemoglobin and methemoglobin. And transcutaneous oximetry, we works on the same principle of transcutaneous gas tension monitor but measures arterial oxygen tension. Whereas the pulse oximeter is most commonly used instrument to measure oxygen saturation. And the accuracy of pulse oximeter is fair and dependable most of the time, but errors also can occur due to delay in response time due to hypothermia or low carbon dioxide or vasoconstricting drug usage. It may give erroneous readings due to motion artifact and hypoperfusion, and SpO2 should not be used to assess adequacy of ventilation. So unless you have a capnometry also or capnography, you cannot say that ventilation is adequate with only SpO2. And what are the recent advances in pulse oximetry? They are doing the error correction by what is called Massimo technology, which automatically corrects the motion artifact and hypoperfusion signal loss. And there is a multi-wavelength pulse oximetry, which again is called the Massimo RAD 57, which is a pulse oximeter which uses 8 wavelengths instead of the 2 which are normally used in the pulse oximeter to measure different special species of hemoglobin, just like your co-oximeter. Then there is a reflectance pulse oximetry probe which is placed on the forehead to avoid motion artifact and hypoperfusion signals. So this is how that reflectance pulse oximeter probe is placed on the forehead, and this is the uh, Massimo rad, which all measures other species of hemoglobin also. Now the new applications of pulse oximeter, when it is having a plethysmograph display, it can be used for measuring the volume, status, and fluid responsiveness also. And they are also used during epidural test dose administration to detect the intravascular injection. And mixed venous oxygen monitoring is also becoming very important. So a reduced mixed venous oxygen saturation is indicative of global tissue hypoxia. And pulse oximetry combined with continuous mixed venous oxygen measurement in patients with acute respiratory failure helps to monitor shunt fraction and help ventilator adjustment. Now, expired gas analysis also is becoming part of the monitoring of respiratory function. This helps to assess the depth of anesthesia by making interference about blood concentrations of agent used. And this is done by either mass spectrometry, infrared absorption, or electrochemical analysis, paramagnetic analysis, and nitric oxide measurements. Waveform analysis of expired respiratory gases is also used for adjusting your ventilation. And the most common what we use is capnograph, which is of course there are two types, mainstream and side stream, and there is also time versus volume capnographs are there. So this is the mainstream analyzer, which is inserted very close to the endotracheal tube, and it has got an infrared source light detector, and you can see immediate. There is no transit delay, so the display will be immediate. So it is real time. This is the side stream analyzer where you take a sample through a tubing and then send it to the machine and analyze and display. So there will be always a time lag when you use a side stream. Earlier, The mainstream was the first one to be introduced, but because it was a bulky equipment, it caused a lot of heat, and it was dragging on the tube. All these disadvantages were there, so they started using the side stream. And in the Viva, you may be commonly asked about what is the length of this tube, what should be the diameter, how many ml of expired air will be drawn for sampling. All these questions you have to answer in the Viva examination. And this is how the display comes. You have a phase 1, which is the inspiratory phase, then phase 2 is the early expiration, phase 3 is the plateau phase of expiration, and suddenly the inspiration starts again. So 1, 2, 3, and sometimes they call 4 or 0, and this is the expiration and this is the inspiration, alpha and beta angle. All these things are displayed in the, based on that you can make all your inferences. And this is the difference between the time and the volume graph. Okay? So this is the time scale and the volume capnograph. That difference also they will ask you in the exam. Next comes blood gas analysis. It's also part of respiratory monitoring. So transcutaneous blood gas monitoring used for rapid measurement of gases, especially of oxygen in infants. It works on the principle of the capillary PO2 to approximate the arterial PO2 when skin is warm, which causes blood flow to exceed the amount required for local oxygen consumption. And this is how this transcutaneous blood gas monitoring in infant is attached, and you get a display here. Inline blood gas monitoring also has come nowadays. When you put in an arterial catheter, you can introduce a probe. Continuous intravascular blood gas monitoring was developed in 1956 after Clark developed CO2 electrode in 1927. So this is how the whole setup is there. You put in an arterial line. This is a normal arterial line, and this is how the probe, optical fiber probe, goes into that same cannula, and that can immediately give you all that. Earlier we were drawing sample and then sending it to the lab to be analyzed in the blood gas machine, but nowadays inline measurements also have come. The advantage is they give continuous data, early detection of deleterious events, decreased blood loss, less time needed, and less risk of transmission of infection, and trend analysis is also possible. How the trend in oxygenation and carbon dioxide levels are maintained and pH is maintained, all that can be done. And the commonly used method is to draw arterial blood and feed it into the ABG machine to analyze. That was the method we are adopting all these days and still being continued in many centers. And patients undergoing cardiopulmonary bypass, two methods of analysis done. One is alpha stat and the other is pH stat. So this I think we discussed when we discussed about cardiopulmonary bypass. And artifacts in ABG which can happen are delay in analyzing the sample when the pH and gas values may change. So you must feed the sample in the machine within 20 minutes, and proper storage is essential. It should be kept in 4 degrees centigrade, and air bubbles should be avoided when drawing the sample. Then comes the pulmonary and chest wall monitoring. So pressure volume curve analysis, which can measure both static and dynamic curves. So this is how the curves are deployed when you use this monitor, and it forms inflation and deflation. And the hysteresis is the word that is used. Do you know what is the meaning of hysteresis, Kamal? Whenever the inflation pathway is not the same, it is a different pathway by deflation, that is what is called the hysteresis. Okay, so the inflation or inspiratory pathway and the expiratory pathway, when they are different, it forms something like a loop, that is called hysteresis. Okay, so there you can use that for as a pressure here and volume here, and that will tell you about the pulmonary and chest wall mobility and the amount that is being done. This is how the graphic displays will come. And you can do analysis level of PEEP, analysis of lung recruitment using CT and electrical impedance tomography. Inspiratory pressure monitoring. Measurement of negative inspiratory pressure is useful. Bedside assessment of respiratory muscle strength and normal range is -50. So negative pressure creation is very, very important when patient is be put on spontaneous mode. So a normal range of -50 to -120 centimeters of water, if the patient is able to create that much of negative pressure, then his inspiratory efforts are quite sufficient, because inspiration is an active process and expiration is a passive process. So whenever you want to wean a patient from controlled ventilation mode to spontaneous, you have to look at the inspiratory pressure monitoring. Then esophageal monitoring, it will help to assess the transpulmonary pressures to determine alveolar distension, which in turn will give the difference between alveolar pressure and pleural pressure. And work of breathing also can have to be monitored. So work of breathing is equal to force into D in the respiratory system. It represents the force needed to inspire certain volume, which can again be rewritten as pressure into volume. Normally, less than 5% of total oxygen consumption is used for work of breathing. But when the patient has a respiratory problem, the work of breathing like bronchospasm or pleural effusion, restrictive or obstructive airway diseases, they can increase the work of breathing up to 40%. So then majority of the oxygen will go for that, and tissues will have less oxygenation and anaerobic respiration will start. Then closed loop analysis, which are seen in the ventilators, which are computer-based real-time interpretations of respiratory mechanics, which helps to continuously adjust level of support to the patient. Ventilation dysynchrony and work of breathing are minimized by observing this closed loop analysis, which are normally also called ventilator graphics. And the examples of this, there are now newer modes of ventilation, which is called proportionate assist ventilation, neurally adjusted ventilatory assist, knowledge-based system, and adaptive support ventilation. Then apnea monitoring methods are also there, which are called transthoracic impedance using ECG electrodes. Nowadays, many of the monitors, if you see when you put your ECG electrode itself, it will measure the respiratory rate and tell you. And there will be a display also according to the movement of the chest, whether you do a mechanical ventilation or during spontaneous ventilation. So that transthoracic impedance ECG electrodes are the methods used for apnea monitoring. Respiratory inductive plethysmography and phonoplethysmography, respiratory muscle electromyography, and monitoring of gas flow and exchange. All these things tell you whether the patient is breathing or apnea monitoring, especially if the patient has got obstructive sleep apnea. This will be very useful in the post-operative phase also. But the best method to monitor is to assess the EtCO2 and SaO2 to confirm there is a proper gas exchange going on. And another thing in the respiratory system, sometimes when the patient develops water collection in the lung water analysis also becomes one of the monitors. So the means of assessing the extent of pulmonary edema, as it measures the amount of extravascular lung water, this is done by radiographic methods and indicator dilution methods. So monitoring high frequency ventilation. HFV is characterized by rapid delivery of small tidal volume and maintenance of high mean airway pressure. So this is how I told you about the history. This is the inflation and exhalation. So you can make a zone of over distension, safe window, de-recruitment and atelectasis. So again, pressure volume loop is plotted, and this will tell you how to adjust the pressure and make the patient come to the safe level, so that you can avoid barotrauma or collapse. So various modes of high frequency ventilation are high frequency oscillatory ventilation, high frequency jet ventilation, high frequency flow interruption, and high frequency percussive ventilation. And monitoring respiratory system during transport, pulse oximetry helps in this regard. If patient requires support of his respiration, better to use mechanical ventilation instead of manual ventilation. That is, assisting the ventilation with an ambu bag is not advisable. You have to go for a transport ventilator so that you will have a uniform and uh, same tidal volume delivered to the patient all the time. Whereas in manual, you are pressing can cause a difference in the tidal volume delivered, and unequal breath can happen. So these are the things that are given in Miller for respiratory monitoring.